It's not just mood disorders that get worse when estrogen falls in menopause, and antidepressants are not the only solution.
Welcome to the Carlat Psychiatry podcast, keeping psychiatry honest since 2003.
I'm Chris Aiken, the editor-in-chief of the Carlat Psychiatry Report.
And I'm Kellie Newsome, a psychiatric NP and a dedicated reader of every issue.
In today's episode, you're going to learn how to assess and manage perimenopausal psychiatric disorders. And we're going to talk about treatments like hormone replacement therapy and novel ones like clonidine, saffron, and L-methylfolate. But first, a preview of the CME quiz for this episode. You can earn CME through the link in the show notes. According to a recent meta-analysis, what percentage of children diagnosed with ADHD also have obstructive sleep apnea? A, 10%, B, 21%, C, 44%, or D, 62%. Pearl number 7, watch for psychiatric worsening in the perimenopausal period.
Last week, we talked about hormonal swings that worsen psych disorders during the luteal phase, the 2-week window before menstruation. Today's episode is not about hormonal swings, but their decline. Many psych disorders also worsen during menopause, as estrogen starts its gradual decline. Once they stabilize in the low range, things get better. But in the meanwhile, you can expect to see more depression, concentration problems, and even relapses of schizophrenia in middle-aged women.
Here are some specifics. Depression is 2 to 4 times more common around menopause. Bipolar depression also gets worse in that time, but mania does not. And there's a message there. Depression tends to be caused by slow changes that grind people down over time, like chronic stress, while mania tends to be triggered by rapid changes. We're talking like the sudden rise in spring sunlight, postpartum hormonal swings, starting or stopping a medication, or traveling in an airplane across more than 2 time zones. Menopause is more of the slow grind that tends to cause depression. Rapid mood swings around childbirth or menses are more of the type that can trigger mania. ADHD also gets worse around the menopause. Like in a survey of 600 women with ADHD, 98% reported worsening during the menopause. And many women without a prior ADHD history complain of brain fog during this time. Binge eating is also going to rise during menopause. And whether anxiety peaks in menopause, that's not as clear. But if you're a psychiatric researcher, there's a gap in need of data.
In schizophrenia, women have 2 risk windows where psychosis can worsen. One is shared with men in the late teens, and one they face alone around menopause. The likely cause is the decline in estrogen's neuroprotective effects on dopaminergic systems.
Estrogen influences many processes in the brain: GABA, serotonin, dopamine, norepinephrine, and it also affects neurogenesis, inflammation, and stress hormones, the ones of the HPA axis. But the brain adapts, which may explain why women do better once the low levels of estrogen stabilizes and their brain is adapted. It's the transition that's the risky time, the perimenopausal period when estrogen is falling and fluctuating somewhat unpredictably, and that period of time can take years when there's a greater risk for these disorders.
Perimenopause lasts an average of 7 years. It typically begins in the late 40s, though some women started in the 30s. Menstrual cycles become less frequent and more irregular. Hormone levels decline without plateauing. You know when perimenopause is over because the definition is clear, defined as a full year without a period.
Here's something else to look out for during perimenopause. For some women, premenstrual dysphoria comes back or might even start anew, especially when the menopausal transition is abrupt, like when it's brought on surgically or by estrogen-blocking treatments for breast cancer like tamoxifen. In our next Pearl, we're going to look at the practical question. So, if falling estrogen is driving the depression and other problems in perimenopause, could restoring estrogen treat it? Number 8, how to treat perimenopausal psychiatric problems.
The first-line treatments for perimenopausal depression are the same ones many take for other depressive episodes, SSRIs and SNRIs. They address both mood symptoms and vasomotor symptoms, hot flashes and night sweats. Among the SSRIs, paroxetine, escitalopram, and citalopram have the most data in this population. Among the SNRIs, desvenlafaxine and venlafaxine.
Other serotonergic agents, including vortioxetine, are likely to help, but the non-serotonergic antidepressants, bupropion for instance, probably don't address the vasomotor symptoms. Gabapentin is another option, particularly when insomnia is prominent. And another good option for perimenopausal insomnia is melatonin. That's where melatonin has a lot of its data.
One practical note. If a patient responded to a particular antidepressant before, that's usually the best place to start again. The evidence base for specific agents here is so thin, so that prior response is a better guide than the clinical trials. And if your patient has bipolar disorder, skip the antidepressant. They can cause more agitation or rapid cycling.
When antidepressants don't work or they're not tolerable, hormone replacement therapy, HRT, is an option. For unipolar and probably for bipolar as well, but the studies are in unipolar. HRT is an attractive option because it addresses the underlying cause. But on the other hand, the supporting studies here are few and they are small.
Here's what the evidence tells us about HRT. For women without clinical depression, HRT improves well-being, energy, and cognition, along with physical benefits, relief from hot flashes, night sweats, vaginal dryness, and weight changes. It also lowers the risk of diabetes and osteoporosis. That's a lot of benefits across a pretty big evidence base. But the treatment nearly got canceled by a large observational study.
In 2002, the Women's Health Initiative reported increased risks of breast cancer and heart disease with HRT. Prescriptions dropped sharply, and clinicians grew reluctant to recommend HRT. But subsequent studies changed those findings. HRT may protect the heart, particularly when started early in the menopausal transition. The picture here is still evolving. Risks depend on a woman's individual history, the type of hormones used, and how long they're used for. During treatment, you need to watch for some complications like excessive bleeding, fibroid growth, and blood pressure changes. Most psychiatrists aren't equipped to weigh and monitor those risks, so I recommend women get this treatment from an OB-GYN. But we're just talking here about the trials of non-major depressive mood in everyday women with menopause. Let's now look at major depression.
When it comes to treating clinical depression with HRT, the data is much more thin. We have 2 small randomized controlled trials enrolling a total of 84 perimenopausal women. Both used HRT as monotherapy. Both were positive. Response and remission rates ran between 65 and 70%. Both used transdermal estrogen, a patch rather than a pill. Transdermal delivery gives steadier blood levels, which might be important for stabilizing mood. In both studies, the patch combined estrogen with progestin to protect the uterine lining from cancer. A third randomized trial found that starting transdermal HRT early prevents depressive symptoms. This one was larger, enrolling 172 women in the early phase of menopause. Compared to placebo, HRT cut the risk of future depressive symptoms in half, especially in women with recent stressful life events.
In schizophrenia, transdermal HRT also treats and prevents psychotic relapse. For active treatment of psychosis, the effect size here is small, around 0.3, and it's supported by 4 randomized trials, a little more than what we have in depression. Another option in schizophrenia is raloxifene, brand name Evista. This is a medication that modulates the estrogen receptor, It's approved for osteoporosis in menopausal women, and it's also approved for breast cancer prevention.
Raloxifene for schizophrenia? I've never heard of this one. Is this another novel med with an intriguing but impractically small trial?
That's what I thought when I saw it mentioned in a 2023 paper called Evidence-Based Recommendations for the Pharmacologic Treatment of Women with Schizophrenia. But they are saying that it's ready for prime time, and they cited 8 randomized trials, one of them large, and 3 meta-analyses supporting it.
Okay, so if you're treating schizophrenia, look up raloxifene and learn how to use it. Then give us a call and we'll interview you for the podcast. But if you think HRT is indicated, we're not recommending you write for it. Contact the OB-GYN directly, explain that psychiatric treatments haven't been sufficient, and ask whether HRT is an option. They'll weigh the risks and follow the medical effects.
And as they weigh those risks, here are the contraindications that the OB-GYN is going to mull over. They're contraindicated, relatively so, if there's a history of estrogen-sensitive cancers, breast, ovarian, and uterine. That may rule it out. So does unexplained vaginal bleeding, or a history of blood clots, pulmonary embolism, stroke, or conditions that raise the stroke risk, like uncontrolled hypertension or elevated triglycerides. To recap, that's only 3: estrogen-sensitive cancers, thrombolytic events like stroke, and vaginal bleeding. If anyone's counting, there's a lot more than 14 pearls in this series because we're still on number 8 and we've already covered 5 treatments and 2 perimenopausal disorders.
Dr. Aiken, I think you're the only one who is counting.
Okay, I'll stop. But what about other disorders that worsen around perimenopause, bipolar, ADHD, or bulimia? For these, we have no direct clinical trials to tell us what to do. But some medications and supplements have separate lines of evidence that if we patch them together, kind of make a treatment plan. Patchwork evidence is a name I'm making up, but it means that we've looked at treatments that have been studied in 2 different conditions separately, like ADHD and vasomotor symptoms, but not in women with ADHD and vasomotor symptoms. So a slight stretch, but not a big stretch. Here's the first. Consider clonidine for perimenopausal ADHD. Clonidine improves perimenopausal symptoms like hot flashes and palpitations, and it also treats insomnia, common in that time, and of course it treats ADHD. Number 2 is L-methylfolate for perimenopausal depression. Now, on the one hand, there's not studies of L-methylfolate in that exact presentation, but this vitamin does treat depression, and it did improve sexual function in a randomized trial of perimenopausal women, so it's worth considering as you personalize the evidence there.
And finally, saffron. This one actually has the evidence, but often gets overlooked because it's an herb. But saffron has 3 large and 17 small randomized trials in mild to moderate major depression, all of which are positive, and a few are in perimenopausal women. Saffron also treats symptoms relevant to the perimenopause, sexual dysfunction, sleep quality, and it has small trials in ADHD. The dose across all of these trials is 30 milligrams a day. A reliable brand is the patented Afron, spelled without the S. It was used in clinical trials and licensed to other manufacturers. Dr. Aiken keeps a list of lab-tested products at chrisaikenmd.com/supplements. Is it ADHD or sleep apnea, or both? That's a tough differential, and today's research update tells us how critical the question is. It's a meta-analysis by Brian Liao and colleagues from the Journal of Attention Disorders that estimates the rate of sleep apnea in children with ADHD.
Last year, I read a paper saying that 1/4 of children with ADHD had sleep apnea, and that woke me up because it suggests that around 1 million children in the US might be taking a stimulant for an airway problem. The new estimate is even higher. Across 11 studies involving 903 children, 44% of kids with ADHD also had obstructive sleep apnea. Flip it around, and you got 28 to 43% of children with sleep apnea are going to meet criteria for ADHD. The limitations of this study is that it is a small data set, and most of the studies involved younger children. We're talking age 7 to 11.
The mechanism is straightforward. Sleep apnea fragments sleep and drops oxygen levels overnight, impairing attention, impulse control, and behavior. The same symptoms we see in ADHD. Adults are also affected. We have less data, but about 20 to 30% of adults with ADHD have sleep apnea, and the rate approaches 50% if we broaden the criteria to include all sleep disorder breathing. There's a key difference between the two age groups. In adults, the main treatment for sleep apnea is CPAP or BiPAP. In children, enlarged tonsils and adenoids are often the culprit, and we clear the airways by removing the tonsils, an adenotonsillectomy.
Now, some children might have both ADHD and sleep apnea, but surgery is still a reasonable first step here. After adenotonsillectomy, half of children no longer met criteria for ADHD at 1-year follow-up, and scores on ADHD rating scales dropped about 30% from 32 to 21.
Methylphenidate can also work, but it doesn't get at the underlying problem. In studies of sleep apnea, this stimulant improved inattention, but not the sleep disorder breathing. And one study found that stimulant usage slightly worsened the apnea index. Stimulants also add extra stress to the heart, which is a major cause of death in sleep apnea. Here's a pearl you can use in practice right now. Atomoxetine is approved as Strattera for ADHD. But this noradrenergic med also opens up the airways and improves the hypoxia index in sleep apnea. If you suspect sleep apnea in a patient with ADHD, get them to a sleep study, and for medication, atomoxetine is a reasonable place to start. Next week, we'll look at a new study of atomoxetine in sleep apnea.
Based on today's study, I'm going to start screening for sleep apnea in every patient with ADHD. For adults, the Stop Bang questionnaire is a good screening instrument. For children, the standard is the Pediatric Sleep Questionnaire. Both of these are free. You'll find them in the link in the show notes, or go to chrisaikenmd.com, click Research Updates, and search for sleep apnea. You'll find a link to the study we talked about on sleep apnea and ADHD, and at the bottom of that is the full Pediatric Sleep Questionnaire.
Learn more about hormonal therapies for depression in Dr. Aiken's book, Difficult to Treat Depression. The audio version is on sale now for $14 at Amazon. It covers estrogen therapies for women, testosterone for older men, zuranolone for postpartum depression, and high-dose thyroid for treatment-resistant depression.